Hi, this is Stacy, the baby maker Roberts. I have put together more than a decade of my clinical experience into developing the first online mentoring program that deals with the ever-growing area of natural fertility. My Baby Maker Network Mentoring Program is an online interactive program where you will learn how to address all aspects of fertility issues. If you are ready to be a part of an atmosphere that helps you build your practice while helping couples build their family, I look forward to getting to know you in the Baby Maker Mentoring Program. Please go to bioceuticals.com.au and click on the Education tab for more information and to register.
This is FX Medicine. I'm Andrew Whitfield Cook. And with me on the line all the way from Oslo is Dr. Hogne Vik, who serves as the Chief Medical Officer with NATO Pharma ASA. A physician by education, he has a long and successful track record in both the pharmaceutical and dietary supplement industries. Prior to joining NATO Pharma, Dr. Vik was the driving force behind the documentation program securing the current position of superb krill oil developed and manufactured by Aker BioMarine Antarctic. He was also one of the key executives in the management team of Pronova Biopharma, securing the US and Japanese market entrances of Omicor or Lavazza, and was instrumental in bringing tonillin, that's the conjugated linoleic acid, to the European and US markets as part of the Natural ASA. Additionally, as Global Vice President of Production Development with Nycomed, Dr. Vik was one of the main forces behind the development and market entrance of Visipac. Welcome, Hogne.
Thank you very much, and thank you for this opportunity to talk with you and also go through some of the things I'm really burning for when you come to human health.
Now, we'll be talking about NATO Pharma's vitamin K2 MK7. And I've long been impressed by the quality of nutraceuticals from Scandinavian countries, particularly, things like fish oil, but there's a multitude of others, including omega-7, for instance. Could you take our listeners through your education and what attracted you first to work with companies like Aker BioMarine, Pronova, and finally with NATO Pharma?
Yes, I will. My background is that I'm born into a family where my father is a physician, and also I have a brother and sister working in the healthcare system. So from my very beginning, I was very dedicated that I had to do something within healthcare and the healthcare system. So I started out as a normal, interested young guy with a medical student and made a lot of research within allergy. And in the beginning was dedicated to work within internal medicine with some advanced thing in medicine. And through this, I made a lot of papers within basic immunology things, and also learned a lot about what is the starting point for a lot of diseases.
Yeah.
So during my career, I ended up to, in one point of time, to be the CEO of the Norwegian Food Research Institute. And in that area, we really identified that it's not only to treat diseases that is important, but also to prevent diseases to develop. And I think this was a real waker for me in that way that then I saw that by working with the good food, good diets, and also working with dietary supplements, it was perhaps an even more important thing for a physician to do than just to treat people that already had developed diseases.
Now, I've spoken about this sort of subject with Dr. Mark Donoghue, an Australian integrative physician, time and again about how were you accepted or not accepted by your orthodox family members in the medical profession?
Oh, that's a very interesting question because I felt strongly that to go into dietary supplements and this kind of preventive medicine was not the highest ranked part of the medical arena.
Yeah.
So just as you said, it was a lot of skepticism.
Yeah.
But I had a lot of advantage through my background because at least locally in Norway, people were aware of what I've been doing. So therefore, it couldn't be totally out of rank if I was focusing on these issues.
Yeah. So are Scandinavian people more accepting of the therapeutic actions and efficacy of natural medicines?
I think that in Norway, we are a lot of fun of hiking, physical activity, and like outdoors life.
Yeah.
And through that, we also realize that it's a big advantage to have a healthy body. And we have the last 30, 40 years been very well focused on what the body needs not to be deficient in important vitamins and minerals. I also have to add that a part of the normal Norwegian diet has been cod liver oil from very, very long time back.
Yeah.
And that was combined with its so little sun, so short summers in Norway, that vitamin D was a deficiency element. So through cod liver oil, I realized during my childhood that we started every morning with a quite high dosage of cod liver oil mixed up with milk in order to get the sufficient of vitamin D.
Yummy.
And I think some of this kind of experience is also a part of the daily life and of a rather positive approach towards dietary supplements in Norway.
You know, you're bringing back memories from my childhood. I can still remember my father giving me, I don't know if you'd know this supplement, in Australia we call it Hypol, and it's cod liver oil, a very milky looking emulsion. And I actually started to like it.
Yes. That's a good start.
So when you talk about the acceptance and the use of appreciable dosages of oral intake of vitamin D, it reminds me of the simplistic approach we have. Same with vitamin D as for vitamin K. You know, like vitamin D is only for bones. So in my nursing, it taught me that vitamin K was only for blood clotting. But I'm getting that vitamin K or the different isomers of it are just, there's a lot more that it can do, correct?
That's correct. And if I'm allowed to take a little of the history for vitamin K, the whole K letter is, of course, associated with coagulation.
Coagulation, yeah.
So it was the Danish biochemist Henrik Dam that in 1929 identified vitamin K, that later has been mentioned vitamin K1, when he saw that a lot of chickens had problems with bleeding when they were bred. So therefore, he started to identify that molecule, and together with an U.S. researcher, Edward Adelberg-Doisy, that found the structure of this vitamin K in 1941. They were given the Nobel Prize already in 1943. So that is why it's called vitamin K.
Right.
But as you said, then later on, and I will say that it's from the 70s, that they also identified small variation, or at least variation in the molecule of vitamin K1, that has been a family of what we call molecule vitamin K2.
Yeah.
And there we have, depending upon the size of the side chain, what we call menaquinones from MK3, 4, 7, 8, 9. And these molecules have different biological functions in the body. If I come back to what you say, that then it seems to be K2 mainly associated with bone, that's correct. Because the first biological research was identified that this MK7, vitamin K2 with the 7 carbons in the side chain, that has a very important activation factor for osteocalcin, that again is important for the osteoblasts to build bone and generate calcium within bone.
Right.
So I guess that was the starting point. And then everybody think that K2 is only for bone. So
that's the first research was actually looking at vitamin K in bone, and that's it.
Yeah, and the reason for that again is that when there were some kind of different diets in Japan, and they identified in Japan that people having fermented soya beans for lunch when they were working out in the fields, they seem to have less frequency of fractions compared to people in Japan, where they had another kind of diet. We go now quite long back in the history. And then when they started this kind of research and saw this difference, they made some analytical work on this diet. And in that diet, they identified MK7. So that is why we then really got some kind of scientific evidence that this vitamin K2 had an impact to reduce fraction, and later on we understood more the mechanisms behind it.
Right. So when you mentioned before about there's vitamin K2 and then there's the menaquinone derivatives, and you're talking about MK7, which is 7 carbon atoms. Is that correct?
Yeah, correct. Yeah, that's the side chain is 7 carbon atoms. Yeah.
So that affects obviously its actions, but does that restrict the actions to MK7, or can your body metabolize it?
It does not at all restrict it only to that starting molecule, because the body will then, it's also a dynamic between the MK4 molecule, MK7 molecule. But what has been the main argument to use MK7 as your vitamin K2 additive is that the half-life in circulation of MK7 is much longer than vitamin K1 and MK4. Right. So also the biological function of MK7 is not that it works once and then it's finished and have to be rebuilt again. It's more like an engine, that you have one facilitation of an MK7 for a carboxylation process, and when that is finished, you start over again. So it then, the same molecule will give a lot of carboxylation reactions in the body.
I see.
So that means if you have a double or 5 times longer half-life, that also have a tremendous impact on the biological function, not only in osteoblast, but in several other cells in the body.
And what sort of actions are we talking about here? Obviously not just bone.
No, that's true. So what we call it the headline, where we have most scientific evidence, is as a major part to understand what we call the calcium paradox. And here is one of the areas I'm really burning for, because we see that to lose bone strength and develop osteoporosis seems to be a more and more health problem all over the world as we grow older as a population. Mm-hmm. And the pharmaceutical industry and all over the world, one has said, that is because you are lacking calcium in your diet. So then please take more calcium. And people have done that, but
hasn't affected.
It doesn't work. It doesn't work if you don't take more or sufficient facilitators that will place the calcium in the right places.
Yeah.
So that means that we need vitamin D3, extremely important to have the best bone metabolism. But also vitamin K2 is fundamental to make the osteoblast to build bone. So therefore, in the calcium paradox, we say, you need K2 to do this, to build sufficient bone matrix. But also you need vitamin K2 to secure that you don't load up epithelium cells, especially inside your arteries, with calcium. Because the secret is that if you have too much calcium in the body, it is a problem for the body to get rid of it. And therefore, instead of getting rid of it to normal ways, it starts to load up calcium where you don't need it.
Yeah.
And when you come to arterial calcification, if you have too little K2, you will then end up to have a more increased and more severe calcium deposition within the arteries, and that will again give cardiovascular diseases.
So I'm imagining that vitamin K2, MK7 must work to dampen inflammation in some way, because to me calcium is the messenger that gets shot some of the time, and that calcium is really just going to places of infection to in a vain attempt, if you like, to help the body wall off infection or inflammation. Is that right? And the vitamin K dampens that?
Yeah, and that is... Now I've been talking about some of the endpoint we can measure, as you say, that also calcium is a part of the end-stage inflammation process when you try to repair things. Yeah. It's also shown but that is more in vitro studies and in animal models that K2 in itself has an anti-inflammatory effect. So then you come into the whole bunch of biological parameters to looking into inflammation or how to inhibit inflammation. And I will say that K2 so far is identified as a weak or to middle strong anti-inflammatory agent. But again, if you combine this, as we talked a little about omega-3, that definitely has anti-inflammatory effects, then you see that if you then have enough of these kind of substances in your daily diet, you will make the necessary repairment or improve your pro-inflammatory condition to a more neutral situation that will be very important to stay healthy. So that is why I think that when you will end up to learn and have a simplified picture of K2 in the future, they will say, it was this anti-inflammatory effect that was the main thing, and that again was very important to resolve some of the major elements with the calcium problem.
But inflammation is a very broad brush. When we're talking about fish oils, then we're looking at sort of an icosanoid action, and you've got other actions like, tumour necrosis factor and the various interleukins. So in what way does vitamin K2 MK7 act as an anti-inflammatory? What's the biochemical pathway there?
Yeah, here I guess it's a lot of answers we do not have yet. So we have been measuring, just as you say, interleukins. We have been measuring a lot of other activation of white blood cells and so on. So far, we are just reporting in our research collaboration that some of these parameters are enhanced, inhibited, and so on. But I don't have the full picture of how the real entrance and major action is. The major thing for us now, and since Natopharma is more a clinical-focused company, also trying to sell this vitamin K2 as a commercial product, we are more focused on more end-stage observation in clinical trials.
Gotcha.
But really, we are supporting mechanistic studies as well, and hopefully we will have a better understanding when you come a few more years into the future.
Gotcha. So when I was first researching MK7, I kept on coming up with this matrix GLA protein, or MGP, and that seemed to be purported or touted as the way in which it had the control of the various actions. Is that right? Am I on the right track there, or is that...
Yeah, MGP, matrix GLA protein, is one that is associated mostly with effects in the arteries. So then we are talking about when you have a measurement for how we can inhibit calcification of arteries. MGP has been identified as the best documented marker.
Yeah.
And if you allow me to talk a little of that, is that osteocalcin, as we talked about for bone, was very long seen as the one and dominating marker for how you develop osteoporosis. MGP has now been investigated for more than 10 years. And again, the major research for this has been done in Maastricht in the Netherlands.
Yeah.
And now it has been demonstrated very strong correlation that if you have a high percentage of carboxylated MGP, then your arterial status is better. You have more flexible arteries, less stiff arteries, and therefore more physiological arteries. And I guess that just now, Natopharma is working very close with another company located in U.S., Immune Diagnostic Systems, where they now are about to have a launch of carboxylation of MGP as an indicator for your blood vessel status.
Gotcha.
Having said that, we know that K2 do not only have impact on these two proteins. I just read a paper saying that at least 19 different biomarkers of proteins are facilitated or activated by vitamin K where MK7 is the most important marker.
Wow.
And then we are moving into a lot of different important physiological processes. And but for to have the educational point of view, let's so far say that we have a lot of knowledge and a lot of clinical evidence that for osteocalcin and matrix gland protein, we have a very good story. And the other more than 17 stories that we have even better clinical documentation before we can come up with statements that really can change people's lives.
Okay, so when you're talking about the association between higher levels of matrix gland protein, forgive my pronunciation, I said GLA, which is erroneous.
Yeah,
so matrix gland protein.
I think you are right.
Yeah, matrix gland protein. So when you're talking about that association of higher levels of matrix gland protein, or MGP, and having higher levels of elasticity, if you like, of the coronary artery, that's the Rotterdam study, is that correct?
You're all right, yeah. But in the Rotterdam study, that was more an epidemiologic observation.
Yeah.
So they were just looking into people's diets, and they asked, what are you eating every day? And then they came up with the rather extraordinary observation that by following people for 8 years, they said that if you have less than 22 microgram MK7 in your diet, and compare that group to people that had more than 36 microgram MK7 in the diet, it was a great difference in both events of cardiovascular diseases, of cardiovascular death, and total mortality. So the differences were 50%.
Wow!
Just when we made statistics on this single component, and these observations made that was just measurement of MK7 in the diet that people claimed to have. And from all that kind of research we have, people are not very specific when it comes to memory of what you are eating. So that was one of the major starting points where we really made an intervention study with MK7. And then this study, I could talk about it for hours, but I will try to do it short. But that was a study sponsored by Nato Pharma, where we had two groups of post-menopausal women. That means after the menstruation had stopped. So they were in the age when they were recruited, around 55 years of age. So 120 took 180 microgram MK7 every day for 3 years, and the other group took placebo. And I've run a lot of clinical trials within the pharmaceutical industry in my past life. So this time we had a compliance of 92.6%.
Wow.
And that means that that is extremely high percentage, and gives also very high confidence to the clinical data, even if the groups are not that impressive.
Right.
So what we saw then in these two groups after 3 years was that for the cardiovascular part, we saw that by using the measurement pulse wave velocity, that in fact says us how stiff your arteries are, because if you have an ultrasound signal, it will go much faster along an artery if it's stiff compared to if it is more elastic or physiological. Yeah. So what we saw in just for that parameter in this study was that the pulse wave velocity decreased in the MK7 group, meaning that after 3 years, the arteries measured were less stiff, more physiologic after 3 years. And in the placebo group, we had the gradually increasing stiffness. Yeah. So this is I've never seen something like that before. So it just says that K2 or MK7 is extremely important for your blood vessels to stay healthy and get rid of this calcification. And as I previously talked about, that calcium seems to be loaded up or stored in the arteries if you have too much of it.
So that was, you've actually taken the words out of my mouth, because I was going to ask about intervention studies, so thank you for that. That's extremely impressive. One of my questions from that is it to say that vitamin K2 MK7 can regress, say, coronary artery plaques, the calcification. Can it actually regress plaques, or can it just stabilise an existing plaque and help the elasticity?
I would I'm hesitating a little now, because I would very much like to say, yes, it can reverse flicks. But where we have the scientific evidence is that we inhibit the calcification. So even if we have improved this arterial stiffness, there might be other elements as well, not only calcium, that improves this pulmonary velocity thing.
Sure.
So therefore, it's sure that we have very clear documentation that as a dietary supplement to prevent development of calcification, there I will home free say, yes, we have data for that.
Yeah.
When you come to you very intriguing question, if that can also be a drug, then I have to say I strongly believe that this is more than 60% sure. But then we need to come into a documentation program, and Dr. Pharma is working on that, because I believe that this in the future might be a drug as well, and even reverse damaged arteries.
Wow.
But then time has to show, and money has to be offered to do that kind of work.
Yeah. So we can't say that at the stage, but we're very excited. What do they say? Cautiously optimistic. Is that the words?
Yes. Yeah, that's a good word. And you put it on, so that's fine.
So what does the anti-inflammatory effects of MK7 mean for other inflammatory-based diseases, not just cardiovascular-related diseases? And what I'm thinking here is, what about things like Crohn's, where, say, a measure of calprotectin is used to look at general inflammation?
I think that when we are extremely excited about natural compounds and the potential very positive physiological effects all over the area, we also must be a little modest to say that vitamin K2 is more not the biggest or most effective anti-inflammatory agent, but it has some effects.
Yeah.
So I think that for people that go with chronic inflammatory processes, as they do with inflammatory bowel diseases, to have a base level concentration of K2 might reduce the clinical symptoms of the disease. But again, then we need to run studies on that. I know also when you come for omega-3 products, it will be the same. It's not the anti-inflammatory effect for diseases that is major effects of the compound, but still it can participate and be not only a cofactor, but a complementary element that can make the body itself more able to take care of a disease without using expensive and rather challenging drugs too big part of the time.
I'm going to concentrate on drug interactions towards the end of this podcast, but because I think it's on the tip of all of our tongues about how does this work with drugs. But first, what about the dose of MK7? You mentioned 120 to 180 micrograms in the Rotterdam study, but what about other conditions? Is there a wide variation of dose, or do you tend to keep it quite tight?
For what we have been doing is to monitor what is the dosage of MK7 needed to have a stable activated level of osteocalcin. That has been used as the indicator when we did the dose ranging studies before picking the relevant dose for our clinical 3-year study. So then we saw that when we increased the dosage of MK7, you ended up to say that 180 gave around 80% of carboxylation of osteocalcin. If you double the dosage to 360, then it was about the same amount of activation. So that is why we ended up with this 180 microgram.
Gotcha.
So for a healthy population that should inhibit that kind of processes that we are talking about, then that seems to be a rational dosage. when we have gone into some proof of concept studies, and here we are working with patients just to see if we can reverse some kind of effects that is still on the pilot part, but we have been working with very enthusiastic physicians that know that, for example, people on hemodialysis with kidney deficiency, they tend to die, a lot of them, not because of the kidney disease, but because of coronary artery diseases. Mm-hmm. So in these kind of patients, you have a death rate up to 30 to 40% per year because the arteries are so heavily damaged during this situation. Mm-hmm. So there we, in collaboration with some physician in Belgium, Brugge, have seen that you really prolong life for these patients. And then we have had higher dosages per day. We have used up to 500 microgram per day, trying to inhibit further calcification of arteries. So this just points to the fact that if you are going into patients, and in patients with very bad, it might be both bone status and arterial status, you might increase the dosage from 180. But again, these data points to the future when we have more knowledge of how this MK7 works in patients.
But if nothing else, that shows quite a degree of safety. I mean, that's more than double the upper dose in CVD. So that shows a wide margin of safety. What would be the highest dose that you'd go to? I seem to recall something like 1,800 micrograms. Is that right, or am I way off the scale?
Sorry, I didn't quite pick up your question around safety, but that I can do because I know, I understand because for safety reasons, when I talked about the history from Japan, then when people there took their diet, the lunch with this fermented soya beans, then we know that they didn't only digest a few hundred microgram of MK7. They digested up to more than 1,000 microgram per day, and we have had no reports from these areas on adverse events or any negative things of health. So in fact, we have a whole history of this old-fashioned, very special course that has said us that human beings tolerate a lot of this. And when we have looked into interactions, can I take that issue now?
Yes.
With other drugs?
Yes.
Yeah, because then we see that if drugs have the same receptor for action as vitamin K2 or MK7, then it might have some negative effects. But the only drugs we are aware of that have the same kind of receptor point is one specific group of anticoagulants, and that is more warfarin, coumarin, and that group of drugs. Yeah. And that these drugs, they have been used in the past for anticoagulant treatment, especially for people with arterial fibrillation or some other tendencies to higher coagulation activity. But again, this is one of my other big passions. We should replace all these old-fashioned red, toxic, poisoned, awful compounds with new and more modern anticoagulants. Because we know from basic research and other things that warfarin in itself seems to be a facilitator to increase arterial calcification. But anyhow, the medical environment, they are using too much of warfarin and coumarin. And just for these patients, if they then use K2 as well, they need to monitor the right dosage of warfarin coumarin again if they start off with K2. Yeah. It's not at all forbidden to combine it, but you will have a new target value and intake that need to be monitored by your physician.
And that goes for any... That goes for any drug that you start or any treatment that you start with warfarin, doesn't it?
Yes, it does. But that is why we always say if you go on warfarin or coumarin, then talk to your doctor if you want to use K2. And but for all other anticoagulants, we have no knowledge that there is an interaction, and we neither have got any kind of safety reports or adverse events combining this with other drugs.
I remember seeing a paper, glancing at a paper, forgive me, I didn't read it, and it was regarding how vitamin K2, MK7, actually helped to stabilise warfarin, but I don't know what dose was used in that study. Any ideas you can give our listeners?
Yes, I can, because we have had communication with a group in UK where they have been working with anticoagulants for a very long time. And then in these studies so far, they had used vitamin K1 and said that if you have a stable level of K1 in the circulation, then you will also have a more stable INR values for your warfarin treatment. And based on that logic, it should be even better to have vitamin K2 or MK7, because then we know that the half-life is longer and you should even more easy have a similar stable level. So within this area, because now we are touching upon an extremely important area for our future research, we would also like to see how for the first thing that the K2 level will have an impact on your normal coagulation level, and even if that can also be more easy for also the modern anticoagulants to give a stable value all over the place.
Yeah, that'd be very interesting, because that's a real issue with the newer generation, the dabigatran and other drugs. There was some sort of talk in the medical literature looking at even, going back to warfarin because they were unhappy with the results.
Well, that has also been because some of the new anticoagulants, they do not have what they call antidote. So if you then have a too high level, it is a problem to stop the bleeding. So I guess this is also an area where you can combine the new anticoagulants with K2. And then you don't need an antidote, but you need then to have more understanding of the total vitamin K2 effects in the body.
Yeah, so it might actually help to make these, the Pradaxas and other drugs more safe as well. Wow.
Yeah, let's see. That might be future data.
Are there any caveats? Are there any cautions that we really need to be concerned about, apart from high-dose vitamin K with warfarin without stabilising your INR first? Are there any caveats of therapy?
So from my perspective and what I've been learned about K2, and I've been involved with this molecule since 2001, I'm not aware of anything else. But of course, if new data are generated, we will look into it from over perspective and really try to understand the mechanisms. But just now, I see very, very small reasons that would pop up.
I guess the safety sort of the safety reassurance comes from the unusually high intake from that Japanese diet ingesting natto. When you said they were 1,000 micrograms per day, I mean that would have been long term. It wouldn't have been just in winter or something.
Yeah, that was long term, and that is also one of the major stories we have been telling when we have got the product approved as novel food in Europe for the grass, generally accepted as safe in US. So then over description over the previous use of natto in Japan has been accepted as a good safety story, taking away a lot of the concerns from the official committees evaluated MK7 as a dietary supplement.
So there's the vitamin K2 MK7 molecule, which is menaquinone from Natto Pharma. There's also some MK4 supplements out there. Is there any difference in the supplements with regards to, say, stability or their actions?
When you come to MK4, that is a molecule that has been approved as drug in Japan and has been tried to be sold as a drug in Japan with modest and small success. Again, when you compare the MK4 molecule and MK7, I would say that the effect seems to be about the same, but that MK4 with a very reduced half-life compared to MK7 need to be taken in milligram dosages compared to microgram dosages. At least they need much higher dosages to get the same effect.
Yeah.
So that is one of the reasons why MK7 is more efficient and also more stable as a molecule in the body. And when you come to the drugs or the pills, I guess it's about the same stability of the two products.
So, what's next on the horizon in the way of research for Natto Pharma? Is there anything that you can allow our listeners to get a glimpse into, or is it all hush hush at the moment?
No. I think that we have been trying to advocating the effects of MK7, menaquinone, as vitamin K2 for about a decade now. And I think that more and more people are aware of the effects for bone and for cardiovascular to prevent development of disease condition here. So in the horizon we now have is to really test out the effects in patients that can take advantage not only to inhibit development from the early point in life, but also to treat diseases and let people have a good life even if these diseases has developed.
Yeah.
And in addition to that, we know there are very many new intriguing observations when you come to effects on the brain, the central nervous system, and effects around the anti-inflammatory effects of the compound. So we have a lot more to do, and hopefully we can come up with new data in these areas also in the years to come.
Wow. That would be very interesting to see how that pans out. I have to ask one last question before we go, Hogne, and that's a rather, one could call it remedial, but it's extremely frustrating for those who have them. That's soft tissue injuries like spurs. Can vitamin K2, MK7, can that act on taking the calcium out of that calcified tissue and dispersing it to other tissues?
If this is the last question, I should really be happy to say, yes, it can. But here I have to say, I hope it can. And let's see if we can help in the future.
Because, it might be a remedial type of medical level, if you like, but it's extremely frustrating for those people who have them. And it actually impacts on a wide variety of activities of daily living.
Yeah. No, I really understand, and that is what we touched upon a little earlier, that when you have repairment of inflammatory processes, calcium seems to be a part of that you end up with this calcification in soft tissue, very many strange places. So we haven't run studies in this area, but we gladly will participate, and if that can resolve the problem, I will be most happy about it.
Wonderful. Hogne Vik, thank you, forgive me, Dr. Hogne Vik, thank you so much for joining us today on FX Medicine. I learned so much by talking to you and having you explain the many areas of MK7 and where the research is pointing to, not just in the past to help with cardiovascular disease and bone, but some very interesting other areas as well. Thank you very much.
And thank you very much for taking the time together with me. I've had a pleasant time. Thank you.
This is FX Medicine, and I'm Andrew Whitfield Cook. This is Andrew from FX Medicine. We thank you so much for your support over the last 2 years. We'd really love to remain clinically relevant to your practice. So if you know of an expert in some area, please let us know. You can contact us on fxmedicine.com.au, Facebook or Twitter.